Hello, my name is Marco Niero, and I'm the CSO of CTF Europe. I wanted to welcome you to this info masterclass, and most especially thank you on behalf of all the patients for your interest in NF. Now, before we move on to the real stuff, I need to give you some instructions regarding the Q&A. You will be able to put down your questions by using the chat box during the masterclass. We would much prefer if you put down these questions in English. If you have trouble formulating your question in English, we could advise you to try to use online translators such as Google Translate before putting them down in the chat box. And if that is not possible for you, please do it in your own language, and we will do our best on our end to have it translated as best as we can into English. Enjoy your masterclass.
I am Pierre Wolkenstein. I'm dermatologist. I'm coordinator of the Referral Center for Neurofibromatosis in Paris. And I'm very happy today to welcome you in a masterclass dedicated and devoted to cutaneous neurofibromas. I will give the voice to Sirkku Peltonen.
Yes, I'm Sirkku Peltonen and also wish to welcome you all to this webinar. I'm from Finland and have been running an NF clinic in Turku. And at the moment, I work in Gothenburg in Sweden. I'm also a dermatologist. This webinar consists of 3 patient interviews, a PowerPoint presentation, and then a video which is showing how to remove cutaneous neurofibromas with laser. And thereafter, there will be time for questions and answers. Welcome.
Could you briefly introduce yourself?
I am Jérôme Fourgeau. I'm 57. I live in Paris and I work in a company in the research development.
When did you notice your first cutaneous neurofibromas?
It's a difficult question because I was too young to notice that. But my parents told me I should have been 3 or 4 years.
How many cutaneous neurofibromas do you have?
It's not easy to reply because in fact I live with the disease since my little, so I don't know what it could be without neurofibrom. But yes, it is an impact on my life. Physically, it's different than other, so I'm a little different.
Are you happy with laser surgery?
Yes, I'm very happy because we can remove little, bigger, and a lot of neurofibrom. So yes, laser is good for me.
Are you unhappy with laser surgery?
No. I can't say I can say that because laser is good. Sometimes you can have some bad effect, like burns on the skin, but it is less than the neurofibrom, so no bad effect for me.
Do you expect a medical treatment?
Yes, of course. I expect a treatment. Pills, anywhere, everything. I will be happy if I have another treatment to test.
Haluaisitko ensin esitellä itsesi?
Olen Harri Nieminen, 62 vuotta. Toimin Suomen Neurofibromatoosi-yhdistyksen puheenjohtajana.
Minkä ikäisenä huomasit ihollasi ensimmäiset neurofibromat?
Varhaislapsuudessa minulla kasvoi yksi isompi vatsan päälle loput, ja varsinaisesti näitä on alkanut kasvamaan sitten murrosiässä.
Kuinka monta niitä suunnilleen nykyisin on?
Ja tuhansia, niitä on mahdoton laskea.
No miten ne vaikuttavat elämääsi?
Ihohoito on ollut vaikea. Minulla on ollut lukuisia ihotulehduksia, jossa olen joutunut IV-antibioottihoitoon. Peseminen, ihon kuivaaminen ja rasvaaminen vievät aikaa. Lisäksi ihoni kutisee runsaasti. Sitten kun ihmiset tuijottavat, kommentoivat, niin se on vaikuttanut henkisesti niin, että on tullut välillä halu eristäytyä. Mutta onneksi vaimoni ansiota olen kyllä itsetunto niin paljon noussut, että se ei niin hirveästi enää vaikuta. Mutta uimahalliin, uimarannoille en kyllä pysty menemään.
Joo. Oletko ollut tyytyväinen lasertoimenpiteisiin?
Kyllä olen ollut. Minulla on otettu lukuisia kertoja laserilla, hoidettu pienempien fibroomien poistossa. Laser on ollut minusta erittäin hyvä. Siihen olen ollut tyytyväinen. Ja isommissa se on isompien fibroomien laserhoito en niinkään, koska niiden paranemisprosessi on ollut hankala.
No odotatko neurofibroomin lääkehoitoa?
Toivon, että sen lääkehoito tulisi vielä joskus, mutta en usko, että tapahtuu minun elinaikana.
Haluaisitko esitellä itsesi?
Olen Saara, 35-vuotias sairaanhoitaja. Työskentelen erikoissairaanhoidossa vuodeosastolla. Olen naimisissa, minulla ei ole lapsia.
No minkä ikäisenä huomasit ensimmäiset neurofibroomat ihollasi?
Kiinnitin niihin varmasti ensimmäisen kerran huomiota murrosikäisenä.
Kuinka monta neurofibroomaa sinulla nykyään suunnilleen on?
Luultavasti 150–200.
No miten ne vaikuttavat elämääsi?
Pääasiassa ne aiheuttavat minulle kovaa kutinaa, osa menee rikki hankautuessaan. En ole kokenut kosmeettista haittaa, koska valtaosa niistä ei ole kasvoissani.
No mitä mieltä olet niiden laserhoidosta?
Laserhoito on ollut minusta aina oikein hienoa, koska se on nopea, kivuton ja haavat ovat aina parantuneet hyvin.
No odotatko lääkehoitoa ihon neurofibroomiin?
Olisi hienoa, jos olisi lääkehoito, koska toimenpiteet ovat aina riski ja infektioriski. Ja olisi hienoa hoitaa niitä kotona myös.
Hyvä. In this lecture, we are talking about some general aspects of neurofibromatosis, about the pathogenesis and content of neurofibroma tumors, how do they look like, and what is the impact of cutaneous neurofibromas on patients' life. And last but not least, we discuss some treatment alternatives. Neurofibromatosis type 1 is caused by pathogenic variants of the NF1 gene. Neurofibromatosis 1 is one of the most common genodermatoses with an incidence of about 1 to 2,000 or 1 to 3,000. It is dominantly inherited and it has 100% penetrance, which means that all who have a pathogenic variant of the NF1 gene have clinical findings. However, about half of the patients have got their NF1 syndrome based on a sporadic mutation. It is their parents are healthy. Diagnostic criteria for NF1 have been revised and published this year. 2 or more in the list are needed for diagnosis. Café au lait macules are the most common first sign, and one needs to have 6 or more of these for diagnosis. Axillary or inguinal freckling is the next to appear in children, and at least one of the 2 pigmentary findings should be bilateral. Neurofibromas are an important criterion, and for diagnosis we need 2 or more neurofibromas of any type or 1 plexiform neurofibroma. Optic glioma or ophthalmological findings are less visible and need special examinations. Bone lesions such as sphenoid dysplasia or anterolateral bowing of the tibia or pseudoarthrosis are less common. Parent with diagnosed NF1 is a strong criterion, and a newcomer in this list is a heterozygous pathogenic NF variant, which means that molecular analysis of NF1 gene has become more important recently. This slide shows typical findings: café au lait spots, axillar freckles, Lis nodules of iris, tibial bowing or pseudoarthrosis, optic gliomas, and last but not least, cutaneous neurofibromas. Like their name tells, neurofibromas have neural elements and fibrotic connective tissue. Neural elements are remnants of small nerve endings in the tumor tissue. And if you cut a neurofibroma, you can see whitish tumor tissue, and in skin, they are usually skin colored. Cellular composition of neurofibromas include all cell types of peripheral nerve, that is Schwann cells, which are S100 positive, fibroblasts, perineural cells, and of immune system cells. Toluidine blue stain shows mast cells. In addition, there are follicular structures in many neurofibromas which contain elements of hair follicle, such as sebaceous glands, muscle, and hair shaft. And the collagenous extracellular matrix contains fibrillar collagen and other collagen types, such as type 4 collagen, which is found in basement membranes. When we think of pathogenesis of cutaneous neurofibromas, there is concept of so-called second hit mutation. A subpopulation of Schwann cells get another second NF1 mutation, and that leads to the disruption of small nerves and proliferation of neural connective tissue cells. The other possible theory is that neurofibromas originate from stem cells residing in skin. Cutaneous neurofibromas are the most characteristic hallmark of NF1. Practically all adult patients with NF1 have these tumors. A few cutaneous neurofibromas may be present in childhood, but they typically start to grow in puberty. How do cutaneous neurofibromas then look like? They are always located in skin dermis, but they may look flat or maybe slightly elevated from skin level, or they may protrude out of the skin level when we call those globular or pedunculated. Patients may have all different types of neurofibromas simultaneously. The most disturbing ones usually are the pedunculated and globular ones, which you can see even through clothing. Sometimes dermatologists get questions concerning the purplish spots on the skin, which feel softer than the surrounding skin, and those are flat neurofibromas. Even though cutaneous neurofibromas may be extremely numerous, they do not undergo malignant transformation. Thus, there is no need to operate neurofibromas because of suspected malignancy in skin. They are also safe to treat with destructive methods, even if you are not able to get a histological sample with these methods. Cutaneous neurofibromas cause the heaviest disease burden in adult patients. Neurofibromatosis 1 is a progressive disease, and the number of tumors increases through whole lifetime.
Logically, we will start by the past on what we know. On this slide, you see the age distribution of cutaneous neurofibromas with 3 curves. The blue line is summarizing the number during childhood. Then the red one will increase with puberty, going to more than 100 neurofibroma with a yellow one after the age of 50 or 60 years old. So we can conclude that age is the main risk factor for increasing the number of cutaneous neurofibromas. The impact of cutaneous neurofibromas can be measured with questionnaires. Questionnaires investigating quality of life or depression. We can also evaluate the visibility of the disease using scales such as Ablon's index. On this slide, you can see the correlation between the visibility of the disease and the impact upon quality of life using Skindex. The more the disease is visible, the more you will have impact on emotion, symptoms, and functioning. It has been reported that patients with neurofibromatosis 1 were prone to develop depression. Using the GHQ-12, we showed that the visibility was directly correlated with the impact and the development on depression. To summarize, we can say that the visibility is a main burden for patients. This is not only the visibility that is giving the impact of neurofibromatosis type 1 on patients, but also the total body image that is affected. In addition to this visibility, cutaneous neurofibromas are itching, and pruritus should be addressed as a main problems for these patients.
About 1/3 of the patients experience daily pruritus, and almost daily pruritus disturbs about 1/3 of the patients. Over 60% scratch, and unfortunately, there is no specific treatment for itch associated with NF1. Based on these studies, we can say that cutaneous neurofibromas are stigmatizing. Patients with more severe neurofibromatosis have more effects on several domains of general health, such as physical function, bodily pain, general health perception, and vitality. And visibility has the major negative impact on quality of life. What can we do then? The treatments for neurofibromas include surgery and various ablative techniques. They can be done in local anesthesia, but they need several treatment sessions because of multiple tumors. In general anesthesia, it is possible to remove dozens of tumors in one session using ablative techniques.
Let's go now to the treatment of cutaneous neurofibromas. The main treatment today is instrumental dermatology and surgical approach. Here you have an example of what is blade surgery. The tumors are excised under local anesthesia, and this technique needs to be evaluated from the viewpoint of patients. The most popular technique to destroy cutaneous neurofibromas by dermatologists in France is carbon dioxide laser. Why? Because it is rapid. You have the possibility under general anesthesia to destroy more than 100 cutaneous neurofibromas, and the scars are acceptable. Another procedure that can be used for the destruction of cutaneous neurofibromas is electrodesiccation. It works by dehydration and denaturation of the dermis. It is more popular in US than in Europe, and it can be used under general anesthesia as well as local anesthesia. I have no experience of the results of radiofrequency, but authors reported good results. Considering the possibility of bad results, keloids, hypertrophic scars, hypochromic scars, it was a necessity to evaluate from the viewpoint of patients their satisfaction or dissatisfaction. Therefore, we performed 2 surveys, one in my center and the other one at the European level. In my center, we obtained sending a questionnaire to patients that underwent the procedure in the past, more than 200 responses. The vast majority of patients were patients with extreme visibility of their cutaneous neurofibromas. And we must say that a quarter of them stopped the procedures and half of them due to insufficient results. At the European level, it was a comparison between surgery and laser surgery. The global satisfaction was good, but we must say that to summarize, the expectation of patients is for better results.
To summarize our message, cutaneous neurofibromas are an unmet health problem in NF1, and visibility and pruritus should be addressed as main problems of patients. The problem is that availability of treatments in public health varies between countries, and it may not be reimbursed by insurance companies. Thus, there is need for medical treatments in the future.
Hello, everyone, and apologies again for this audio glitch, which has been solved now. Thank you for being here today. I will be moderating the Q&A session. We have a first question coming from Carol Gorham. There have been rumors for quite a while that an ointment is being developed that people with NF can use on their cutaneous tumors. Supposedly, this ointment, if used daily, would remove tumors and keep them gone. Is anything like this really being worked on? And if so, what is an approximate time frame?
I can answer the question. There is a trial in US from a company that is called NF Election that you can consult on the web. And there is a trial trying a kind of gel that is a MEK inhibitor that is used usually for treating plexiform neurofibromas in children. And they developed a MEK inhibitor in a topical gel that could shrink the cutaneous neurofibromas. So it is really the early stage of development. To answer the second step of the question, when it will be available, I do not know, but if it works, the fact that you have a trial now, if you look at, for example, for MEK inhibition in plexiform neurofibromas, the first publication was 5 years ago, and the approval was last year. So that means that at least 5 years to have something available for patients could be the minimum or the minimal time frame.
Thank you, Pierre. We actually had a partial answer from Lars Eriksson, who typed in the web address for the clinical trial you were just describing.
I do not have the website, but it's NFLECTON, and you type right on your Google, and you will find it.
I have put it in the chat. It came in the chat room.
Perfect.
Yeah. Another question from Britt Danes. Are there any criteria for treating cutaneous NF with the CO2 laser? And do they need to be a certain size? And alternatively, is there a maximum size?
These are very good questions. I would not treat on hands or feet, which if you are not totally sure that it's in the skin level, because they are very sensitive and special areas. It's very good question whether it's better to treat small or big, because if you treat the small one, you leave a scar and you never know whether it was going to grow bigger. But of course, if you treat small ones, then you leave smaller scar. The big ones, I think I have taken a lot of about 2-3 centimeter big from belly or back, but it leaves quite a big wound for several weeks. So I would rather stay in around 1 centimeter or 1-2 centimeters.
In my center, it's exactly the same. The rule, but of course, you can make exception to the rules. It's a diameter of 1 centimeter, less than 1 centimeter laser surgery, more than 1 centimeter, it's more surgical dermatology. Because as told by Sirku, the time to heal is really increased after 1 centimeter, and the scar is sometimes very visible. So that is a limit of the procedure.
Of course, it's if it's a pedunculated or globular tumor with very small, so which is coming out of the skin, it might not leave so big wound. But if it's in the skin, then it's definitely better to leave the biggest ones for regular surgery.
We have another question from Federica Chiara. She'd like to know what is the percentage of recurrent skin tumors after the CO2 laser, and can a comparison be made with other tumor removal techniques?
I would say that if you really extrude the neurofibroma, you will remove all the neurofibroma. That means that there is no recurrence. But what is the meaning of no recurrence? You can remove one neurofibroma, but you will not prevent the growth of other neurofibromas. So sometimes it is told by patients that the removal of neurofibromas will be linked to the regrowth of others. I do not know if it's true, but it's something that is said. To summarize, I think that if you exclude totally the neurofibroma, you have no recurrence, but it will not avoid more neurofibromas after. So that means that you will have the procedure, for example, each year or each 2 years in order to have acceptable results.
I completely agree. But I also have noticed that patients who have had their neurofibromas removed with regular surgery, they tend to grow new neurofibromas in the scar area. And I've been thinking it's possible because of the stitches have irritated the skin. So I would say if you want one area without tumors, you use laser rather than surgery. But it's just exactly the laser area which is not growing, but 1 millimeter side might grow another one.
We're having many questions coming in. Another from Lars Eriksson. Your slides show greater satisfaction for surgery rather than the CO2 laser. What do you think of the robust surgical approach paper? And is this method better than laser? If you have come across this paper.
No, the question of, I discussed this point with Lulé. The question of dermatological surgery, it is a limitation of local anesthesia. The difference between laser and robust blade surgery, it is that probably the scars are better with dermatological surgeries, that's clear, but the number of cutaneous neurofibromas that you can remove is really small. When you are looking at the table of the paper of Lulé, it is rarely more than 20 cutaneous neurofibromas. So that's why we chose more laser surgery when you have numerous cutaneous neurofibromas. But I agree that this treatment is not ideal.
Still on the theme, another question from Lars Eriksson, who says that he saw a presentation by a surgeon in Los Angeles who used percutaneous alcohol injection for a small subsurface tumors. Is that a good idea?
It's a plastic surgeon from Los Angeles. If you look at the website of the guy, and I know him, the results are very good. Again, the question is probably the balance between the number of cutaneous neurofibromas that you have to remove and the technical issues. Again, I think that the conclusion of patients, and my conclusion and the conclusion of CIRCU, is that we have an unmet need of medical treatment and to prevent the growth of cutaneous neurofibromas. That is also an option in the future.
Then we have a few questions on prevention as well from Sara Brebbia. Do you have any experience with or thoughts on using topical mTOR inhibitors for early stages of neurofibroma development?
CIRCU, any idea?
I think that question was already a little bit answered, but I don't have any experience, but it would be, of course, a great possibility if we had that kind of topical gel, which, for example, in face, if you see tiny little neurofibromas starting, then it would be great possibility to prevent.
To answer the direct question of mTOR inhibition, I tried, we use mTOR inhibition for angiofibromas in tuberous sclerosis with a great success. And of course, I tried off-label to treat cutaneous neurofibromas with mTOR
inhibition without any success with a topical gel or topical cream ointment that is done with sirolimus. So my experience is it doesn't work.
And still on the prevention theme, a question from Ellie Day. Is there any research around strategies to prevent the formation of tumors rather than directed at treatment?
So I can say I do not know any prevention possibility in human beings, but we have some results and good results in the mice model that we developed in Paris. That means that if you put topical or if you take systemic MEK inhibition, if you are a mouse, but we are not a mouse, you can prevent the growth of cutaneous neurofibromas and even avoid the development of them. So we can imagine theoretically the fact that you can have a sequential treatment, for example, at the age of 18 to prevent with a cycle of MEK inhibition or MEK inhibitors for 3 months. But I must highlight that the number of cutaneous neurofibromas is not predictable. And to treat in prevention, somebody in which you will not know if he will have 2 neurofibromas or dozens of neurofibromas. It's today the race to biomarkers in order to predict the appearance of cutaneous neurofibromas. That will be the great deal of the next future.
And we will possibly see within 10, 15 years how the children who have now been on MEK inhibitors, if they are going to develop neurofibromas when they are adults.
Another question from Blanca Diaz, still on the theme, I suppose, is if you have any experience with imatinib to treat cutaneous neurofibromas.
I know one patient that is under imatinib for another disease without any result on cutaneous neurofibromas. But it's a case report. It's not a case report. It's a case. It's only one case. I know somebody in France that used trametinib in the treatment of cutaneous neurofibromas systemically, and it was the results were not too bad. Systemically. And there is a trial of selumetinib in US in Birmingham with the team of Bruce Korf that is ongoing.
Another question from Carol Gorham. Do the cutaneous tumors that grow between skin layers stay there, or do they develop into the cutaneous tumors that are more visible?
I didn't catch the question.
Do the cutaneous tumors that grow between skin layers, do they stay there, or do they develop into full-blown cutaneous tumors that are visible?
Maybe he's thinking about those tumors which grow between dermis and subcutis, but I would say they stay there. If originally, if the skin is moving over the tumor, it's under the dermis, and then it will not come out. But if it's within the dermis, those can start growing above the skin level.
Agree. It was typically a question on subcutaneous neurofibromas that are under the skin.
A question from Luisa Rodriguez. How painful is the CO2 laser after the anesthetics wash off?
I would say that the burner is more on dressing than for pain.
Yeah, the patients usually, they say it's not painful at all.
And still on the same line of thought, a question from Federica Chiara. Is there any difference between the scar that is generated after the laser treatment and the scar that is generated after surgery?
Oh, yes. Yes,
So in other words,
it's I would say it's more a round scar when you are doing laser, and with hypopigmented or and hyperpigmented skin, sometimes no pigmentation. For surgery, you have a line.
Yes, is that due to a different reparative or inflammatory response in any way?
No. It's only a technical issue.
Yes, and with surgery, you may also get the stitches like ladder, so that there is a line and then the stitch marks. But after laser, the scar is usually on the skin level, and looks, I think, looks better in most cases.
Then we have another question from Rebecca Brown. How do cutaneous neurofibromas respond to systemic immunotherapy?
I have no experience of systemic immunotherapy in cutaneous neurofibromas.
Me neither.
And yes, another question from Sara Brebbia, and this should be the last question. When do you recommend that neurofibromas are removed with surgery or laser? Is it better to remove them while they are still in the nascent stage?
I would say my strategy is to ask patients. So there is a balance between the benefit and the risk of the treatment, but clearly for cutaneous neurofibromas, that is the burden for patients. I ask the patient, but then I will see if the scar will be more visible than the cutaneous neurofibroma. So to answer clearly, it's a balance, and no prevention with surgery and laser, if I can say that. You need to have a constituted cutaneous neurofibromas to destroy or to remove.
Okay, sorry, Sirku.
Yeah, I agree.
Another question from Lars Eriksson. Do you have a theory for what hormonal changes are represented by puberty that cause tumors to start developing? Or does that suggest a possible drug discovery approach?
We know that the tumor cells in neurofibromas, especially Schwann cells, they contain estrogen receptors. So they are hormone sensitive, but otherwise I don't think that is probably not the line of treatment or development of medicines.
So there is probably an hormonal influence of under cutaneous neurofibromas. It's seen in pregnancy, but I would say that hormonal modulation is not a strategy that I would support.
Yeah, but they are hormone sensitive tumors in the way that they react to hormones.
And we have a question from somebody who puts his name in Cyrillic. I'm sorry, I can't pronounce it, but is there a difference in phenotypic manifestation of cutaneous neurofibromas and certain types of mutations of NF1? Want to know if there's a genotype correlation.
It was described that microdeletion of the NF1 gene were linked to numerous cutaneous neurofibromas. Could you confirm, Seku, if I am right?
Yes, but there are also patients who have huge tumor burden, but no microdeletion. But patients with microdeletion, they definitely have developed maybe earlier than the others, develop cutaneous tumors and more in number.
And we have another question that's come in from Tamara Hasbun. can you describe the electrodesiccation procedure and how that differs from laser?
Again, I have no experience of that. It's done in US, and the principle of that is to dehydrate the tumor. So it's not a thermic destruction. It's a dehydration, a way to destroy the tumor. But I would say electrodesiccation, laser surgery, or even the use of electricity to destroy neurofibromas, it's the same. Laser surgery is used because it's practical, but it's not the only way to destroy neurofibromas.
Yeah, and I think if somebody has a lot of experience in one method, then that's the best method. So if
absolutely,
yeah.
Okay, we have a very difficult question coming from Sara Brebbia. Are there any data supporting that patients with an OPG tumor, an optic pathway glioma tumor, leading to oversecretion of hormones, have a higher risk of developing cutaneous neurofibromas at an early age?
No, my experience, but it was not published, it is that people with optic pathway glioma, with symptomatic optic pathway glioma, have less cutaneous neurofibromas.
And we had what I think is the last question, but they keep coming in, from Meredith Fanelli. What treatments do you recommend for pruritus?
I do not know. No, it's a real issue. I use antihistaminic pills, but it's not very useful. So there is no treatment that I know to have proven efficacy. Sirku?
Yes, but one also has to remember that patients may have itch because of dry skin, atopic skin, or sweat. So regular skin care might also help a little bit if it's not exactly the tumors which itch.
The last question from Federica Chiara. I would like to know if you're thinking of developing topical treatments.
Yes. No, I think as told by Sirku, for the face and the hands, it's really something that that should be done with MEK inhibitors, clearly.
Well, I think it's been a very lively Q&A session. We should close now this webinar, and I thank everyone for their attendance, and Pierre and Sirku, of course, for being here with us. And I hope to see everyone again in the next webinars of our program.
Thank you very much to everybody. Have a good evening. Thank you for your attendance. Au revoir, Sirku. Au revoir, Marco. Au revoir, everybody.
Have a nice night.
Bye-bye.
Thank you.
Bye.
Yeah.